Hello, everyone. We are Group 22 from the Faculty of Health Sciences at Ontario Tech University, presenting for HLSC 3805U, Introduction to Epidemiology. Our group members are Grace Shempong, Kwende Ambrose, Liz Conley, Kuzi Mupeti, Valerie Savard, and Beverly Sang.
My name is Kuzi, and today, along with Valerie and Kwende, we will be presenting our research proposal exploring the question, does physical inactivity increase the risk of coronary heart disease? We'll discuss why this question matters for public health and how epidemiology allows us to examine the connection between lifestyle behaviors and disease risk. Let's begin with the background and significance of our study.
Our study aims to determine whether low physical activity increases the risk of coronary heart disease, CHD, in adults aged 30 to 65 years. This question is vital because 1 in 12 Canadian adults, about 2.6 million people, live with diagnosed coronary heart disease, and approximately 14 Canadians with coronary heart disease die every hour, based on the data from the Canadian Chronic Disease Surveillance System. Physical inactivity is a major contributor to coronary heart disease. Increasing physical activity is well established as an effective primary prevention strategy, yet only 45% of Canadian adults meet the recommended 150 minutes of moderate to vigorous activity each week. According to Statistics Canada, people who meet activity recommendations have about a 14% lower risk of coronary heart disease compared to inactive individuals.
Our study focuses on adults aged 30 to 65 who do not have coronary heart disease or stroke at the start of the study. This age range allows us to observe new cases of CHD over time. Participants must be able to take part in physical activity assessments so that we can collect accurate and safe data. With individuals with existing CHD, stroke, end-stage disease, or significant mobility limitations. These conditions can affect activity levels and distort the accuracy of our measurements. Setting clear eligibility criteria ensures we are studying a comparable group of at risk for CHD and for its data reliability, consistency, and participant safety.
Our study will use prospective cohort design to examine whether physical inactivity increases the risk of coronary heart disease. We will recruit men and women aged 30 to 65 who are free of coronary heart disease at baseline and follow them for 10 years to track new cases. Physical activity will be measured at baseline using validated questionnaires and wearable devices, giving both self-reported and objective data. Participants will be grouped by baseline activity levels to compare coronary heart disease incidence across different categories. A prospective cohort is ideal because it confirms that exposure precedes disease, helping establish a temporal and potentially causal relationship. Measuring activity before CHD onset also reduces recall and reporting bias and allows us to calculate absolute and relative risks of CHD in inactive versus active groups. This design is the gold standard for chronic diseases with long latency. It allows adjustment for key baseline confounders such as age, smoking, diet, BMI, and socioeconomic status, so we can better isolate the effect of physical inactivity on CHD risk.
For our recruitment process, we will partner with family medical clinics, which already maintain complete medical histories, allowing us to efficiently identify participants who meet our inclusion and exclusion criteria. We'll use random selection from clinic rosters to obtain a diverse, representative sample across ages, bounds, and health conditions while reducing selection bias. Clinic staff will assist with initial screening, and eligible patients will be invited by phone, mail, or in person during routine visits, which is an approach that leverages familiar settings to support trust, higher response rates, and smoother follow-up. To maintain strong retention, we will collect multiple contact methods at baseline, phone, email, and alternative contact, and maintain regular communication throughout the study. This strategy enhances recruitment efficiency, supports long-term follow-up, and helps preserve statistical power by minimizing loss to follow-up in our prospective cohort. Our primary exposure is habitual physical activity, specifically moderate to vigorous physical activity, or MVPA, and sedentary behavior measured objectively with a wrist-worn accelerometer. Participants will wear the device 24 hours a day for 7 consecutive days at baseline, and again at 6 months, allowing us to capture weekday-weekend variation and reduce recall and social desirability bias. A valid day is defined as at least 16 hours of wear, and a valid week is at least 4 valid days, including 1 weekend day. Participants who do not meet these thresholds will be offered 1 rewear opportunity within 14 days. Our main exposure variables will be MVPA minutes per day, sedentary hours per day, and total activity volume. For interpretability, we will also classify participants as meeting or not meeting the Canadian 24-hour movement guidelines while retaining continuous device-based measures for analysis. In addition, we'll administer a brief questionnaire, such as the IPAC short form, to capture activity domains that accelerometers may underrepresent and to triangulate our device data.
Dependent variable. Primary outcome. New coronary heart disease events such as myocardial infarction, clinically confirmed angina, and coronary revascularization such as angioplasty and CABG. Events will be validated using medical records, hospital data, registry information, and ICD-10 codes and clinician review. Secondary outcomes, changes in a validated CHD risk score, e.g. Framingham, ASCVD, and changes in risk factors such as systolic blood pressure, LDL cholesterol, A1C, waist circumference, and BMI, measured at baseline and follow-up. Additional follow-up, if possible, extended CHD outcomes will be assessed through administrative data, and overall, the approach captures both major clinical events and early physiological changes that may occur before CHD develops.
Cohort studies are vulnerable to confounding variables, so it's important to acknowledge and control for them, especially since many factors contribute to coronary heart disease. Key confounders include age, sex, gender, obesity, socioeconomic status, family history, smoking, diet, and various health conditions. By controlling for these variables, we can better isolate how physical inactivity affects the risk of coronary heart disease. Data will be collected from participant questionnaires and verified against medical records at baseline and follow-up. Controlling for confounders helps reduce bias and strengthens the validity of our findings. We recognize that some unmeasured factors may remain. In our statistical analysis, we'll use a multivariable regression to account for these variables and isolate the effect of physical inactivity. This approach increases confidence that any association we observe truly reflects the impact of inactivity on coronary heart disease. One limitation of our study design is that cohort studies are prone to certain types of bias. Because we will be using self-reported data, there's potential for recall bias and self-reporting bias. People may forget or misjudge how active they actually are. Social desirability bias can also occur, where participants over-report activity or under-report unhealthy behaviors to fit social norms. These issues can make our exposure measurement less accurate and weaken the observed link between inactivity and coronary heart disease. Loss to follow-up is another concern, as missing data can reduce statistical power and introduce bias. Finally, unmeasured confounders and non-compliance with wearing accelerometers could affect data completeness and the overall validity of our findings.